All right, so hello everyone. I'm Jaime Jordan. I'm one of the APDs over at Harbor UCLA, and welcome to the Fish Tank. This is going to be an expert consult in education research. I am very lucky to have an incredibly talented group, an expert panel in education researchers, and I'll introduce them to you in just a minute. All right, so what you're going to get from the tank today. So we are going to showcase two outstanding education research proposals that have been selected as finalists from a general call for education research proposals. Our expert panel here, I like to call them our Guppy Panel, are going to actually provide feedback and highlight the strengths and weaknesses of each of these proposals and identify some common pearls and pitfalls in education research. Our hope is that you're going to walk away from this session with some concepts of best practices in education research that you can then take and apply to your next study. All right, without further ado, here are our expert panels. We have Dr. Stephen Cico, who is the Assistant Dean for Graduate Medical Education here at Indiana University. We also have Dr. Sally Santen, who is the Senior Associate Dean for Evaluation over at Virginia Commonwealth University. And then finally, Dr. Michael Gottlieb, who is the Director of Ultrasound over at Rush University. All right, so let's get started. Our first presenter and finalist is Dr. Lucian Lefty-Clayton, who is from Tufts and is going to present her proposal, Crikey, Save a Mannequin, Stab a 3D Model, researching a more cost-effective cricothyrotomy trainer.
Hi. Thank you all very, very much. So I apologize that we have changed from Tufts to UMass, and so I have to plug my new school. So I have a real interest in airway education specifically. And recently, I recognized that there was an area for improvement in our airway education, specifically with front of neck airway. Right now, we use mannequin trainers. They are exceedingly expensive. They're thousands of dollars each, and they're excellent trainers, but unfortunately, they're so cost prohibitive that I can't do efficient education with these really often. And what I realized was 3D printed larynxes are able to provide really good fidelity in terms of the anatomy, and they're very cheap, $1 per larynx. So I can buy a whole bunch of them and use them for training. But what I found in the literature was that these two modalities for learning open cricothyrotomies have not been compared yet. So our proposal is to directly compare these neck to neck. So the first thing we're going to do is to give a pre and post survey to test how the residents felt that this experience went, what was their satisfaction, and what was their knowledge of this very critical procedure before and after our intervention. The second stage is we're going to put them through a simulation of a can't intubate, can't oxygenate scenario. That will lead them to needing to do a front of neck airway, and we will actually be looking for how did they acquire the skills, all right? Did they get the skills that they need? The way that we're going to do this, our study design right now, is to separate our residents by year and then randomize them to either the mannequin trainer, which we already use, or to the new 3D printed trainers. Once they're randomized, they'll get the same multisensory education module on doing front of neck airways. That will be followed by the hands-on training session equal time, right, either in the mannequin group or in our 3D printed group. After that, there'll be a 2 to 4 week delay before they'll get their simulation. So we'll see a little bit of what the skills are and how they got retained. The way that we're going to evaluate that acquisition of skill is to videotape each of the residents as they're doing the simulation and the airway, specifically just on the neck. That'll allow us to blind the raters to who the resident is, and it'll allow them to use an assessment tool that's been developed and utilized in ENT literature for open crics. In summary, we're going to be directly comparing the standardized mannequin that's used for open cric training with a 3D printed model, and showing that the 3D printed model performs similarly in the experience and the knowledge acquisition, and finally, probably most importantly, the skills acquisition. of a really critical procedure. We anticipate that this research will then lead on to research looking directly at using this much cheaper model and seeing what kinds of curriculum models work best for, again, the acquisition of the skills and then retention of skills.
Great, thanks, Ann. All right, comments from our fish tank.
All right, so I think it's a really interesting study. I like the idea of both assessing from a relatively Kirkpatrick level 1, like a basic assessment, how do they like it, but then taking a delayed 2 to 4 week assessment of an actual outcome of how well they're doing it. I like that you're doing this with simulation and making it more real. I like that you are using a checklist. One comment on that is you said it's an ENT checklist, which is probably a different criteria than we do. Likely it's probably at least going to use the rake and other aspects of things that we don't typically do for our open criteria. Has it been validated in the so one thing you think about is, has it been validated in the EM literature, or has it been assessed at least from a content validity standpoint?
It has not been validated within EM literature. I have not found anywhere that it was used in EM literature. Looking at it, it's actually, from the standpoint of someone who's so invested in airway education, it's a really good tool because it's very simple, and then following with a Likert scale of how. Bill Soares, who is my collaborator in this, we were talking about this today, and we're anticipating that we're going to have to take that tool and actually, one, use it between attendings, probably someone else doing the airway than one of our residents, and then actually look at what the interoperator reliability is of this tool, and obviously all of those people will be EM.
And I would suggest writing that up too as a validation for the EMT tool as a separate study. That being said, just a couple other things that you may not have gotten into because it's a shorter presentation is just thinking about stratifying by group, because assuming it's going to be all your residents or just one class?
No, so it'll be all 3 classes, and we were planning to stratify by group.
Perfect. Yeah, stratifying group.
3 minutes was very short.
Things got cut. I don't want to take up too much time. That's long as Sally.
So I think it's a really nicely designed study. I think you've got good outcomes. I think you've got a big issue of sample size, because it may be that you actually don't have the sample to prove that they're equal. I'm not horribly experienced with this, but you may want to try what's called a non-inferiority study. This is you're trying to prove that they're equal, but your sample size is going to be critical, because you may not find a difference because you're trying not to find a difference, or you may not find a difference because you don't have enough residents. And so it might be useful, clearly if you're doing video review, you could invite another institution to join you, and you would have an adequate sample size. But I think it's a very nice study.
Yeah, and along those lines, the other thing before you invite other institutions would be talking to a statistician and just trying to get a number from them so that you actually have the number that you'll need.
Absolutely.
So, but otherwise, I agree. I think this is a really nice study, and I like what you're assessing, the way you're doing it. So, good.
Thank you.
Great, thank you. All right, so our next finalist is Dr. Sarah Hawke from Rush University, who's here to present her proposal, High Fidelity Simulation as a Modality for Attending Physician Recredentialing in Conscious Sedation Privileges. Welcome, Sarah.
Thank you. So the study I'm proposing is related to continuing medical education, but still is within the realm of education. And this is along one of my interests with attending physicians and how we maintain and ensure that we are maintaining our skills and those of the fellow clinicians that we either supervise or work with that may do these procedures infrequently. And one of the examples of this procedure that's done infrequently by some specialties is conscious sedation. At our institution, we have approximately 200 physicians that are credentialed in the procedure of conscious sedation and hold credentials to perform it. And an opportunity this year came to me that instead of doing the recredentialing exercises via an electronic online platform that takes approximately 3 minutes to complete and is relatively superficial, to place this educational opportunity, re-educational opportunity perhaps, within the auspices of a simulation lab. And so the design of this study is to look at basically interspecialty, because there are a number of specialties that are involved. So emergency medicine is one, neurocritical care has privileges, cardiology, pediatrics, all these different specialties have privileges for conscious sedation. And the study I propose is more of a kind of pre and post study of what skills these physicians have when you bring them in and do a simulation scenario cold in the simulation lab with a proper pre-brief and orientation to the sim environment and those types of things. But really, here is a simulation that involves a complication to your conscious sedation. What did you prepare? What did you anticipate? And how do you manage your complication? And so there's a checklist that I have developed based on the American Society for Anesthesiologists recommendations for non-anesthesiology providers doing conscious sedation. And that checklist will be done after the first case with a debrief, and then immediately following that, a second case with the same team of between 3 and 5 physicians performing a different case with a different potentially complication, and looking at the checklist following that case. So a relatively immediate, hopefully, improvement in the performance might be seen there. And after that, probably several months delay, we would do a survey to ensure that the key points taught in this recredentialing process were retained in a way that potentially could be evaluated by a multiple choice type of survey. And so that would be an emailed survey to all of the people who maintain the credentials and say, hey, please, as part of your credentialing, complete this survey. So kind of a two-part, including retention of that kind of continuing education experience in the format of hopefully a nicely organized study. So that's my proposal.
Great, thank you. All right, comments from our panel.
So I think I read the proposal and I'm struggling a little bit with method, so I'm just going to kind of review the method. So it's essentially, it's a case with a debrief and a checklist of confirming that they have met certain actions, and that the thought is that that intervention, as an educational intervention, will improve their behavior on the second case. I think that's what I'm getting in terms of objectives and methods.
Right.
Point being, it's not clear, neither in the presentation or the proposal. And so some clarity about what is exactly the objective. So your theoretical proposal is that by running a simulation in faculty who have not done this before, you're going to improve their performance on the subsequent stimulation. So I think that's kind of the question, and that you're measuring it in two separate measurement outcomes, one being immediate, being the checklist after with the first case, and the second one being a delayed survey. I think it's, you want to just push back, it might be important to go back and look at delayed survey information, because I think what we know is, I was probably at a conference 3 months ago. I'm not really sure what I remember. And I'm not sure, I think delayed knowledge testing and delayed behavioral testing has a lot of validity, but I think delayed satisfaction and comfort testing probably is not particularly helpful. It is, but it's not. I'm just not sure that's commonly used.
And I apologize, that was a misstatement on my part. It would be a delayed knowledge test to see if the specific items that we discussed as being required or part of the station were remembered.
Got it. Okay.
So one of the things that I like about this is that we're trying to do an actual real assessment of our competencies and our credentialing, as opposed to that checklist that we all kind of quickly do on the computer while we're doing 10 million other things, because, well, if I get it wrong, I can retry and get it again. So I definitely appreciate that aspect, and I think that's really nice. One thing I struggle with along the lines of what Sally was mentioning is I wasn't quite sure if you're trying to assess, can simulation teach, because then you're assessing how well they learn the competency afterwards, or is simulation effective to gauge their ability to be credentialed? And that seemed a little bit confusing between there, because in one regard, if you're going to use simulation for teaching, then we have to figure out what we're really trying to teach them. Are we trying to teach them to use this actual checklist, or to be better at simulation? And the step to that would be, I would at least, at the very least, make sure you have a crossover study, so that half are getting one case and case number 2, and you're flipping them to see how well they learn.
I didn't have enough time to mention that I kind of randomized who starts with which case. Yeah.
And that, naturally, a 3-minute presentation is hard to summarize a huge study. But yeah, I think just clarifying out what the total goal is in terms of, I want to teach that they teach them with SIM or I want to evaluate them with SIM, and then targeting the outcomes a little bit more to that.
And then the other thing in follow-up, just thinking about completing the picture of behavior as well as knowledge, would be some kind of assessment of whether their behavior has changed. And, you know, it would probably be hard to bring them back to do another simulation to see if things have changed. But you could at least, if nothing else, ask a few questions in the follow-up, and I don't know if you were planning to do that, to assess whether they've made any changes in their behavior because of the intervention. So.
That's a great addition to.
Yeah. I think it's, regardless of the methodology and however it is, I actually think it's very publishable because nobody has looked, people are not looking at our lack of competency. And so while the methodology of simulation teaches something nobody's interested in because we've already proven that, oh my God, they've actually lost this and here they've gained it, is an interesting to say it's kind of a mandate that we need to be doing this, a call to action in some ways. And so I think even though the educational question is not interesting, the mandate to action is interesting, and so I think it's a very reasonable and publishable piece. There's a couple of confounders that you're going to want to keep track of. One is the specialty. Two is the number of procedures that they have done, of this procedure that they have done in the past year.
Which is information that I'm collecting.
Exactly. And then I might do a pre-comfort. I think the other thing, because what you're trying to really get at is the shock value of what they have forgotten. And so some sort of a comfort level, because I think you might get some interesting things. Oh, I feel perfectly comfortable with doing sedation, and then their score is a 2. And so I think that might actually help with your call to action, which is kind of your purpose. There was an old study, I believe, it's coming out of Chicago, Northwestern, probably McGahee is the guy. There's an ACLS one that does this, that actually it's probably 10 or 15 years ago, where they did ACLS training and then brought people back 3 to 4 months later and did it. But you might want to use that for modeling in terms of methodology.
And reference Dunning-Kruger as well.
All right, thank you. So now we're going to give our Guppy panel here a little bit of time to sort of deliberate, consider the strengths and weaknesses of both proposals, and then come up with a winner for the 2018 Fish Tank Award. Are we ready, judges? All right, so the first runner-up in the SAEM 2018 Fish Tank Competition is, I have my little envelope here, Dr. Sarah Hawke. Congratulations. And then the winner of the best research proposal for the 2018 Fish Tank is Dr. Sien Lefty-Quating. So I just want to say a big thank you to our 2 finalists, to our expert panel. Hopefully you guys have gleaned a couple of tips that you can take home to make your next research proposal the best it can be. We are over time already. It was a very short session. I apologize for that. But we did make a handout that we think includes the sort of the essentials of an excellent education research proposal. So please refer to that. And then we'll hang around a little bit up here and if anybody has any questions. Thank you and have a great afternoon.